Allie Hobbs. I'm the current chair of the Young Professionals Community Practice. And I wanted to first start by introducing the Society for Health Systems to those of you who might be joining us for the first time. So in general, our mission is to improve the lives through better healthcare delivery, and we accomplish that in a number of different ways. The main one is creating a culture of continuous improvement with healthcare organizations. So that's what we're trying to do here on this call. We want to really cultivate a community of all healthcare improvement professionals. Although we're linked heavily with industrial engineering majors, we really want to expand that into any healthcare improvement professional and anyone really interested in creating that culture of continuous improvement. So in addition, we foster innovation and problem solving through conversations like we're going to have today, developing healthcare leaders, professionals, clinicians, and students, and hopefully influencing leaders and decision makers on the future design of healthcare.
Make sure that we do pull it back. The rebalance effort is a significant portion, because if we have expensive parts, we don't want to be wasting the asset, the money.
You can mute yourself if you're not.
In a location that doesn't, and buying it in another location. So the rebalance is very important. The other thing that happens is we have many low frequency demand items.
Who's talking right now? I'm sorry. If we could like go on mute.
Yep,
Was that
sorry.
you, Allie?
No.
Okay. I tried to look to see if it was coming through on someone else's, but okay, go ahead. Sorry.
So a quick overview of the young professionals community, and I know we have also the experienced professionals also on this call, but we want to create a network and again help develop the young professional students, whoever we can get, learn through sessions like this, and attend and create a community at the Society for Health Systems annual conference, which is the Healthcare Systems Process Improvement Conference. We just had it back in February in Savannah, and we're going to have the next one next February 2021, and that will be in Orlando. So if you're interested in joining us, please go to the IASD website or contact anyone who's on this call.
Okay, so I'll take over from there. Thank you, Allie. The purpose of today's think tank is to really have a collaborative discussion on the impacts that COVID-19 is having on us professionally in healthcare, and what, many of us are industrial engineers in healthcare, but there's a lot of different roles represented on the call as well. So we really want a chance for everybody to kind of weigh in as well. So what we'll do is first, I'm going to go over I was trying to find the mute all button. But what I'd like to do is, if you do have something you want to contribute, you can either, I don't want everyone to speak up all at once because we have a number of people on the call. And so really trying to figure out this format. But what I'd like to do is, there is a way you can raise your hand over on the right in the participants. And you just, if you want to raise your hand to speak, you can do that in here, I believe. So let's see. So yeah, so like Allie just raised her hand there. She was able to raise it. So if you have something you want to contribute, we'll try and do it that way to keep it orderly. And I'll just kind of go through the list and look for people that have their hands raised to add them. And then when you're contributing for the first time, if you could state your name, where you work, your role, and then which question you're responding to, which will make more sense in just a second. But before we get into the detail of these discussion questions, which it's kind of a little bit of a free-for-all, where if you have something you want to provide about one of these questions, we're going to let you do so. But first, we had Avi Fishman, who he prepared a little something, which, you all should have prepared your own PowerPoints, just kidding. But Avi put something together just to kind of start the conversation and get it going, and then we'll see where it takes us from there. So Avi, I've unmuted you. You can go ahead and just let me know when you want to flip slides.
Okay, let me know if you can hear me.
Yep.
Okay, I'm assuming everyone else can hear me. So good afternoon, everyone. My name is Avi Fishman. I'm the Director of Process Improvement for the Memorial Healthcare System. We're located in South Florida, in Broward County. Everyone knows where Fort Lauderdale is. We're not too far from them. As you can see, we have 6 hospitals, and these 6 hospitals, 5 are primarily adult. One of them does a lot of rehab, and we have a children's hospital. In the middle there, you see the Hard Rock Cafe Hotel, which is between all of our sites. You can go to the next slide. We've been called in to work on 2 major initiatives for our healthcare system, and they relate to helping the organization get the vital supplies that they need, as well as help the organization get the vital staffing that they need. Aaron, you're welcome to, there we go. So this is my team. I have a boss. I have 5 people that work for me. 2 are managers, the other are specialists. They're basically situated throughout the hospitals, although one of them is a pinch hitter helping us out with all our initiatives. That's Natalia on the bottom. They're all MBAs. They all have belts, primarily black, and those that are green are studying to become black. You can move on to the next slide. So I want to first thank the people that have been doing this work, although I'm trying to stay on top of all the work. I have Sloan Niles, who's a manager on our west side, covering 2 hospitals. Up here, our principal, sorry. This is what we're all about. Typically what everyone else is all about as well, trying to reduce waste, reduce costs, but respecting the people that do the work, because without them, the ideas that we come up with really mean nothing. We need to listen to them because they're the experts. We're just the facilitators that help them make the work happen. Okay, here we go. So Sloan has been asked to come in to help us with vital supplies. As all of you are aware, everyone's running out of PPE. We're trying to stay on top of it. We've come up with a way to work with our central supply and purchasing folks in order to get a count as to where they're at today, the beginning of the day, and where they're at the end of the day. Hopefully getting all this information from our various sites will enable us to look at what we're using and develop a forecasting model in order to be prepared for when things get really hard. Of course, purchasing is working on getting us everything that we need. Eventually, we may run out if we're not on top of things. So Sloan has been working diligently with them in order to set everything up. And basically, we've gotten everything set up. So now the data can be inputted on a daily basis. And this information now is being turned over to our business intelligence folks that are now working on a model to be able to predict when and if at all we'll run out of supplies. You can go to the next slide, Aaron. So we love mapping things, so you can look at the current state and the future state, and I apologize if it's not big enough or clear, but if anyone wants a copy of this afterwards, I'd be delighted to share it with them. But as you can see, Tableau is the data source to which everything will be imported, and at the touch of a button, because every hour on the hour things are being updated, at the touch of a button, people will be able to see in our leadership how we're doing with our supplies. So a special shout out to Sloan Niles and Melissa Gallo that have been working on this particular initiative. You're welcome to go to the next slide because I want to answer questions rather than talk to everything we're doing. The next project that we're working on deals with staffing. So as you can imagine, supplies are important, but if you don't have the people to do the work and wear those supplies, you're going to be in a lot of trouble. And although our outpatient volume has been cut dramatically and our inpatient volume has also gone down, you need to have the right staff at the right locations in order to deal with the influx of patients and the complexities that those patients present. So we've been working together with our IT folks, our human resource folks, our directors of nursing, our CNOs, in order to come up with a way of being able to get staffing to where it needs when it's needed. You're welcome to go to the next slide. In developing this model, we have to first determine where the needs are. So there's a repository of needs, and then of course there's a repository of those resources that are available. And of course you want to make sure that they have the right skill sets. So putting all this together from a pool of 17,000 total employees, we only have to focus on those employees that were truly needed. So primarily nurses and technologists, and if need be, other skills that are needed. So that reduced the pool dramatically. And now we've been working together in developing the tool, which should be rolled out first thing next week, in being able to have the organizational hospitals get the staffing they need by indicating what the needs are and having a traffic cop get them what they need. So the cool thing is when this is all over with, we'll be able to use this to be able to share resources when they're needed in a non-crisis mode, because we haven't been successful at doing that. But right now we need to do this so that people from one hospital can go to another in order to help them out when they're needed. So those are the slides that I wanted to share with you on the two major initiatives that we've been working on to deal with this crisis on hand. I'm done talking. We can move on to wherever you want to, Aaron. Thank you for sharing that.
Thank you, Avi. So I guess what we can do is if you have questions for Avi, or if you want to contribute to any of the 4 questions that are listed here on the discussion on the screen, just do the raise your hand feature in WebEx, and I'll unmute you and let you know that that you're the one that'll be speaking. So just if people want to start raising your hand out there, and if there's anyone in particular that wants to jump in, either asking Avi questions, like I said, or going in and answering one of these questions. Okay, so if people are having trouble finding it, it's over here on the right hand side in the participants. You go to when you see the list of participants, and you can raise your hand there. Maybe people are having trouble finding it. I know Jordan Peck. Oh, I see Elise Stevens. Elise Stevens, I'm going to unmute you.
I'm here too, Aaron.
Okay, great.
Hi.
Okay,
Hi. Thank you.
Yeah.
Thank you so much for presenting and putting this together. This kind of is a little bit unrelated to what was just talked about, but I just kind of had a general question, if anyone has any feedback on effective ways for screening employees upon entering work. Our health system right now is taking temperatures at the door. I know another large health system in a city next to us is handing out masks to everyone who enters the hospital. So I just was curious about your take on that.
Yeah, and if anyone wants to respond to that, again, you can unmute yourself through the WebEx. You're able to do that, or if you want to raise your hand, I can unmute you either way.
Hi, Elise. Can you hear me?
Absolutely. Thank you.
Yes. So in our organization, we do have a triage station kind of set up in the vestibule, and we're taking temperatures before employees come in the door, and then they either get a yellow or a blue band. A blue band means, they're good to go. A yellow band means that, they have a temperature or something like that, and we ask for them to be sent home at that point. So everyone walking around within the building is expected to kind of show their blue band or, have it visible throughout the day.
That's wonderful. Thank you.
Mm-hmm.
Any other thoughts on that question from Elise?
This is Jordan.
Jordan, go ahead. Yeah. No,
So we're a health system of 8 hospitals, and we're trying to coordinate our work. Of course, right now, not only are we dealing, like many people, with shortages in PPE, there's actually a shortage in thermometers as well. So taking everyone's temperature and making sure there's enough thermometers available and all that is an interesting question that we're trying to deal with. The other piece to this, of course, is the still unknown amount of transmission that can occur with COVID, even when you're not showing symptoms. And, obviously, you don't want to create a false sense of security by taking the temperatures and then saying, feeling like, oh, well, they didn't have a temperature, so they're fine. So I think our organization is mostly leaning on that tactic of just trying to minimize visitors as much as possible first. But we are considering the temperature one as well.
Thank you.
And it looked like Muyan, you had your hand raised as well. I don't know if you had something to add.
Yeah, so hi, this is Moya. I work for Baycare Health System. We are a 15 hospital system in the Tampa Bay area. So far we actually created almost like 4 types of ways to help employee and also help the community to screen symptoms. And the first one, like Alice said, we do check temperature every day at each of our facility. But also on the other side, we provide a self-screening chat box online. So our employee can use that to screen through their symptoms, and that would direct them to either go to a Baycare Anywhere, which is a telehealth visit, or go to our certain. So we actually dedicated certain urgent cares for only screening COVID patient or patient who has respiratory symptoms or temperature, that kind of thing. So that way we can separate patient coming in with normal medical need and then the COVID patients. And then the third way is we placed telehealth bot, like a kiosk, in some of our facilities. So if people do feel sick or something, they can use that. And the fourth way is that we also have nurse stations set up in, right now, I think in 3 hospitals, and we want to expand it later. And we also created a drive-through testing, so where you can really get your swab and then you will know your results. That way, that's how we are controlling it. And I also want to ask a question that is there any good ways for, because I know like a lot of people right now coming with symptoms come through our ER. So ER is actually one of our main channel for those patients. But we also run into situations that patients go to primary care sites or some wound care clinics, that raise a big concerns about like making other even high-risk patients or normal communities get infected. So what kind of methods or things you are doing in your organization to control that? How do we help to not get more people, especially the high-risk patient, get infected? Almost like how do you channel your patient?
Mm-hmm. Anyone have any thoughts on that, on the question from Muyan? Again, you can either raise your hand if you do want to respond, or unmute yourself and start talking. Either one works. And you have to unmute yourself on the WebEx, not on your cell phone or whatever.
So some of the strategies that have been used up here in New York have been telehealth to your primary's office, leveraging them as a triage prior to entering the hospital scene. And then dependent on the situation and that patient's acuity, they would advise either home quarantine or to head to the ER, predominantly based on symptoms. So that's kind of how they've been managing it from the outpatient setting to eliminate risk of additional high-risk population patients entering the ERs looking for treatment. And then once they arrive in the ERs, they're trying to funnel them to a separate section of their EDs and then to designated units as they are investigating those cases.
Okay. Thanks, Erin. Okay. Elise, were you raising your hand again?
Yeah, I have a quick question following up with those great suggestions. When you're putting out like the surveys, not the surveys, but the like the pre-screenings, what has been the most effective way that you're broadcasting that, in the sense of like, is that through social media? Is that through signage on your facility doors? I'm just curious how to boost that message to your patients.
This is Moya.
Josh, this is
Go
Josh
ahead.
at UW, or UW Health in Madison. So we're doing something similar. So we've restricted access to only certain points of our large hospital and clinic building. So patients are expected to go through one door to answer some screening questions, and then if they flag, they might have to wear a mask. A lot of the broadcasting that we are doing, we have done it. One, social media is one thing, just through Facebook. We've also been pushing out MyChart messages, so we are on Epic there. And then we're also pushing out messages through email if people have provided those. So a lot of different modes of communication.
Thank you.
That's great, Josh. Thanks. All right. So I think what I'll do now is let's go through, just kind of go through these questions one by one, because that may spark some conversation. And I think for the first one, Jordan, I know you contributed a little bit ago, but the email you had sent about the types of problems your team is being asked to solve is something interesting that I think others might find interest in as well. So the question is, what are the new problems that your hospitals are trying to solve, and what creative solutions are they implementing thus far? So Jordan, do you want to kick that one off?
Sure, yeah. You know, and actually it's interesting. I have, Aaron knows this, and Avi as well, that I've got this network of performance improvement leaders up here in New England, and we all sort of sent a rapid fire emails to each other saying, hey, what are you working on? What are you working on? And for the most part, we're all working on the same stuff, which is really interesting. So, you know, the first thing, which has been mentioned already, is supply chain. Now, we have supply chain analysts who do a great job pulling the data and understanding what's going on in supply chain. My team of engineers, who have really never been engaged in supply chain before because they've always done their own analytics, my team of engineers have been asked to come help with some of the displaying of the data, helping turn it into, you know, the supply chain was great at making tables, but actually turning it into something that can be a really useful dashboard to drive operational decision making. So they're doing a lot of analysis with leaders and to understand the kind of information they need and how to take the supply chain data and make it consumable. I'm working on a forecasting model where I actually, am I able to share my screen, Aaron? Is that something I can do?
Yeah, let me make you, give me a sec.
Well, while he's making that happen,
I'm working on it. Hold on.
Yeah. I've been sort of tasked, me and one of my other engineers, on designing a forecasting model. I mean, everybody wants to know what's going to happen. There's no very clear way to forecast it accurately. I mean, all the, you know, obviously if there was a magic model, it would have gotten published already. So I've been doing a lot of analysis on the different kinds of forecasts that are being made and how to predict what's going to go on here. And then from there, I've been asked to then take that and say, okay, given a forecast of how many patients are going to get COVID over time in the state of Maine, what will that do to our census, our expected census? And so I've developed that, and I've actually used Power BI to develop, to take my spreadsheet and make it into a very useful graphic, which then gets uploaded every day. then senior leaders can regularly check in on that. I also overlay the current data to show, how are we actually doing in terms of our forecast versus where we are. And
so
ideally,
you should be able to share your screen now, Jordan, by the way, just FYI. Sorry.
All right, let's see. I'm trying to look for how.
So it's like the third button over. It's like got the little up arrow on it. If you click that.
Yeah. Oh, wait, but it's saying my browser doesn't support sharing. I'm on an old browser. I'm going to take a screenshot for you, Aaron. I'll send it. Well,
okay.
It doesn't really matter. I'm describing it.
That's
it's okay. So, so, everyone, so basically it's a bunch it's an S curve, expecting how many people will actually get discharged. And then I multiply, right? So, or not discharged, how many people get COVID? And then I multiply that by 15% to try and figure out how many people will get admitted. That number's all over the place depending on where you're, where you're located and all that. But we, decided to give it a shot anyway. And really what this is doing is helping. A lot of leaders seem to want, of course, they want some clarity, right? They want to be able to plan. Okay, we're going to have this many patients, so this is how many med-surg beds we need. And there's forecasts that are all over the place. There's one organization, the COVID Action Now, which has a website, and they're, at least for Maine, their forecasts are just absolutely ridiculous. I mean, they're forecasting that literally every person in Maine will have gotten COVID by the end of April, and that's just not feasible by any model. Sooner or later, you get the herd immunity and all that. So, making these models, working with leaders to try to validate them and help them get some data on how many patients we can expect, get some baseline of max census that we can expect in the ICU and in med-surg beds and so on. So I'm working on that. And then while someone else is talking, I'll try to log on using a different web browser, and then maybe I could share if people are interested in learning more. But other projects that keep on coming up is we've got labor. People want to know, using the forecasting model, what kind of labor are we going to need? Do we need to repurpose some staff to do other things? They want us. We're working on some of the documentation stuff. I don't know if everyone uses the HICS model, the Healthcare Incident Command System, but that requires some documentation and formal project management. So my team is helping with that as well. One random project that came up is we have a parking garage that our employees shuttle over. So they needed some data analysis to figure out how many increased runs do we have to have in order to reduce the number of people on the shuttles so that they can sit 6 feet apart. So lots of random things come up every day, and someone calls me and says, we need a project manager now, and I assign them. So it's been a lot of chaos, but it's also been really cool because as improvement specialists, a lot of times our projects have 3 month, 4 month, a year-long timeline. And now these projects are rapid. You do something, you're in a bunch of meetings for 2 days, you make a decision, and it gets rolled out. So my team is really enjoying actually getting some rapid impact.
That's great, Jordan. Thank you. Does anyone have any questions for Jordan or anything else to contribute some of the different types of problems that you've been working to solve in your hospital?
If I could jump in, I'd like to also add that things that would typically take us months to do are now taking us days to do. When you ask for IT to work on a project, they would never get to it. But now, by some miracle, they're able to pull it all together and make things happen. So it's great to see that in a time of need, we're all able to perform miracles. I just wish we could perform miracles more often, but it's really great to see this sort of turnaround.
So, hey, this is Wyatt. And one of the things that I'm working on is building a rapid cycle change management and agile project approach for these temporary projects. Is anybody else working on that type of approach right now that we could perhaps join forces offline?
Josh, it looks like you raised your hand there. I didn't know if you wanted to respond to that or if there's anyone else
Yeah,
that's working
Josh
on something similar. Yeah.
Wyatt, did you say you were building just more of an agile approach? Because I think that's a question just that I have for the group, since we, I think everyone might have to deal with being somewhat remote and minimize just physical contact. We're getting shorter timelines, so rather than like 6 months, we're doing something in 6 days, and then we're also doing, a lot of new teamwork. So I'm just interested in how people are approaching framing the problem, going through the team building, going through just making sure that we make progress on something, and then closing out. So
yeah, so I'm Agile certified in addition to project management and Lean Six Sigma and change management. So I'm really adopting an Agile focus, but even then it's going to be a little more complex since we're bringing in people who aren't really familiar with working on projects. So I'm building a formal process from start to finish for how those project needs get identified, and then what the process is for assembling the team, and they're going to check in and which tools they're going to use to drive the process. And it's going to be, so I'm building a little broader than what we need for any given project. And then each time a new project comes up, whether it's PI team led or someone else in the organization leading the work group or task force, and they're coming to me as the first step, and we're discussing the needs and actually building a formal strategy, and I'm giving them the tools that they need.
Yeah, it looks like Valerie has her hand raised there. Valerie Bowman, do you have anything?
Hi, Aaron. How are you?
Good.
Good. I want to go back to something that Jordan was talking about, and he was mentioning some predictive models that are out there in terms of where we think the surge is going to happen. I'm curious to know what other people are using. Right now, we have a potential partnership with a company called Cuventus, and they've pushed out a model that's free to anybody, and we can literally search for your hospital, and it will tell you where your spikes will be. Are there other models out there that people are using that they have validated? I know Jordan said there were some that looked ridiculous, but there are others out there people are using that that they think look pretty good?
Yeah, I wrote the name of that for people if they want to go look that up, Cuventus, how to spell it.
If you want, I can show you. I don't know if you can control, but I can kind of show you what their modeling looks like.
Yeah, do you want me to make you presenter?
Yeah, if you can do that quick.
Okay. Let's see. Come on. Nothing's as quick as you want it.
Never.
Let's see, change role. Presenter. All right, so I just passed it to you, so in a second you should be able to click that share your screen button.
Okay.
Third one from the left. There we go.
Okay. Can you see my screen?
Yes.
Okay.
Yeah.
Can you see this with the big purple banner on top?
No, we're seeing the one that has the WebEx on it.
Now can you see it?
I think change to share your screen instead of a specific application, I think. There we go.
Okay. Let me, can you see this, or this is in a Chrome? You probably can't see it. 1 second. Technical difficulties.
Hey, we're learning on the fly. It's no problem. This is Agile.
So this is
there we go.
So this actually says you can see it better in Chrome, which is why that's where I had it open. And this is actually, now it won't do it here because I'm not in Chrome, but you can actually pick your hospital. So in this one you can't, but if you're in Chrome, it actually, I can type in Iowa Methodist Medical Center, and you can adjust for different scenarios, like how many elective surgeries you're canceling and PPE conversion, your market and will draw out for me when we think our spike is going to happen. So in Chrome, it looks actually very beautiful and gives me some really good information. I was just curious, have other people found tools that they feel are good? As I've been using it, I think it's really quite nice.
Valerie, Aaron, this is Keon. I've seen a tool, a forecasting tool from Penn Medicine. It's called Chime. I've tried to use it a little bit. It has, you know, some of the parameters that you really need a good guess, like the doubling time and the percentage of hospitalizations in that area, regional population, things like that. But it is a free one to use if you want to give it a shot.
Cool.
Hey, this is Moya. We have challenges predicting. It's more like we don't really know when the peak will happen because we wouldn't know when the curve will start going down, and how the social distancing really have an impact on us. That's one challenge in the predictive model. And the second challenge for us is like, even if you can predict like a good new admission, we also have, you know, difficulties to understand the length of stay, because a lot of data that we read from literature review from Asian doesn't really match with Italy, or we don't have a lot of clarity on the US cases. So if you want to, you know, really predict your census, you really have to know length of stay, that kind of information. So I would be curious, you know, anybody want to share any other kind of model they use that they sort of, or a good way to do a sensitivity analysis, say at least this is a reasonable range, what kind of approach people take?
Yeah, this is Jordan, just because I am working so closely on the model. I will say that what I do is I'm updating it as I go. You know, I've built all the parameters so that I can change them. And then I sort of say, look, this is a model based on our current best knowledge. And I am 100% wrong, but it's more than nothing. And as we get more data, I'll update it. And so basically I'm updating my model and even refitting it every day as new cases come in.
And there was another question, it looks like from Mary Beth, but she said she had a lot of background noise. So is anyone using simulation like Simio, FlexSim, et cetera, to predict census?
This is Muyan. I actually tried. So I tried with like I actually used the COVID Act Now model. As you know, Jordan mentioned, it looks pretty crazy because it only predict the next 120 days. So you look like everything will go crazy in April. And I plugged it in. So that's how I tested how the length of stay would play as a factor. We make assumptions like if you have, you know, patients stay with us for 4 days at average versus 7 days versus longer, how would that impact us? It just showed, you know, how the peak will shift and sort of give us a range of days instead of just a particular day, like second week of April. More like give us April through the first week of May, that kind of thing. But for now, I don't think that's like super helpful because it's heavily rely on your volume. Like if the volume is not, then the simulation wouldn't tell. But I'm open-minded. If any other people tried other type of simulation or other problem to use simulation to find answers, I'm willing to try it.
All right. Any other similarly related questions or any other types of problems that you all are working on, you know, day to day? Different than, it sounds like the rapid cycle of improvement is kind of a surprising side effect of this. But you know, what other types of problems are you working to solve, or if there's any of the other questions that you're interested in answering, please jump in.
Hey y'all, Hi, this is Annie. Sorry, I was late to the call. I was out.
That's okay.
We're using trailers to do kind of rapid triage before patients enter the emergency department. And we're kind of doing a lot of rapid improvements. Sorry, my brain is fried because I've been living at this hospital. But we just had a rapid improvement around PPE because the way we had the trailers designed, we had 2 separate clean rooms for the providers to go through. And the state of Illinois just said, you're reusing all PPE now. We're too close to a shortage. And so we just went through a rapid improvement event, which was a group of 6 people standing in a trailer. And we figured out a way to kind of back and forth where we still have one clean-ish room that wouldn't really meet standards any other time. But yeah, again, we're doing a lot of, just let's do these improvements now, and then we'll revisit it if it's still a problem in the future.
Okay. It sounded like someone else wanted to jump in there.
Yeah, I think I have a question and a comment. First one around labor management. We are trying to capture as much of the excess labor cost as we can, when in fact we anticipate we will have to report to the board as to why we're over in labor. We might have to report to the federal government for reimbursement on the labor aspect. So I was just curious if folks are thinking about that, one, and maybe two, are you throwing that extra expense into a cost center? Are you creating a job code for those that may be volunteering to take temperatures or make phone calls to cancel elective procedures? Because thought about how to capture that cost so we can report it out later.
So my health system, we're doing cost centers for each site.
Awesome.
Something unique for us is we canceled all outpatient visits, which I think a lot of places are doing. But we have a surplus of people that want to work right now. And so people are all asking to kind of come in and help fill in spots right now, but we know we're going to need them in a few weeks. So right now we have a lot of people that want to work and can't, but we're charging them all to this new cost center so we can track it. But I think our labor costs are probably actually down because we have so many outpatient clinics.
Well, that's a good problem to have. Awesome. Anybody
Is there
else?
anyone else has, any feedback on that one?
Yeah, this is Josh. Similarly, we are tracking everything in one specific cost center for the system. So when we're redeploying people, that they're getting logged into time in that cost center just to track hours.
Yep. Extremely helpful. Thanks, guys. Good to know we're running down the right path. So that's good. Secondly, it's just a comment, and my organization is a GPO, and I just wanted to give everybody a heads up that we've had over 1,100 emails come through our disaster response email box about what is traditionally called gray market supplies, right? A guy saying, hey, I have a truck of masks. Hey, I have a warehouse of respirators. Whatever it happens to be, whatever is coming through our member hospitals, they are sending that to our GPO. And with all of the vetting that we have done on the supply chain side, we have not found one positive gray market that was not a hoax. So just a warning, I think, to all of our hospitals and all of our supply chains, as you are probably getting barraged with sales and recommendations and opportunity for more PPE. If it's not from a legitimate company, we have not found that one has been valid. So just a warning.
Hey, and who was that was just speaking? Someone, Kay Cole, it sounded like wanted to connect with you, so they want to know who that was.
Well, yeah, this is Marcy Jackson.
Marcy Jackson, okay. Thank you, Marcy.
Hey, Aaron,
There's
this
a lot
is
of act now or lose out on your supplies emails that we get to, so you're not the only one.
Yeah.
Yeah, it's really disappointing actually, but I guess it's our reality, right?
Hi, this is Allie. Oops, I just dropped something. Sorry, this is Allie. I don't have necessarily a response to the cost center question, But I've been working in a very rural hospital, so they actually had on the table the option of closing down the hospital completely and sending all of their staff home, just because they're not a big hospital in general, and they don't do a lot of, they're not getting a ton of COVID response right now. All those patients are going to other hospitals in the area. So something we've been asked to do in order to keep the staff engaged is to come up with a proposal on what the staff should be doing with all the elective surgeries being canceled, and basically most of their inpatient units are shut down, closed off. So we've been trying to come up with ways that they can prepare for when the hospital essentially reopens, even though it's not officially closed, and ways they can deploy their staff, whether that be inventory counts, preference card cleanup, different things that allow them to be prepared when this goes back into normal everyday life. So I don't know if other people are experiencing the impact that COVID-19 is having, like the opposite of they're not flushed with patients. They are essentially too rural that their patients are not there. And what are they doing about that?
So it looked like Scott Siegfried had his hand up a little bit ago. Sorry, I missed that, Scott. If you would like to provide some input.
You know, this is Jordan just answering that last question. I don't have a great answer other than to say I feel you. We do, you know, we have 8 hospitals in the system. A few of them are large medical centers, but 5 of them are small 25-bed critical access hospitals that are bracing themselves, have canceled elective procedures, but have not only have not received any COVID cases, they have no COVID reported in their community at all, in their county at all. And so there's this sort of question of what do they do? I mean, should they start taking patients again? Should they, you know, stay closed? And the answer to that is not clear. Part of being an integrated health system, one of the benefits is we are starting to think about, can we send patients to those hospitals? You know, usually they have 1 or 2 critical care beds or med-surg beds, and can we offload the large academic medical center with patients who are recuperating? Can we send them to another hospital? So I don't know if you're part of a network or have partners in, you know, other local large academic medical centers, but you might want to think about whether you can help them a little bit.
Yeah, thanks, Jordan. This one is not a part of the system, which is, I think, the panic of some of these hospitals who haven't been bought up by systems yet. So right now they're estimating a $15 million loss if this continues. And so we're just, we're trying to think of, there's like 2 sides to this COVID-19 coin, and we don't know. I haven't heard anyone discussing what are we going to do with those hospitals. So it's interesting.
Yeah, absolutely.
We have a rehab hospital that's a little bit out, and our 4th tier plan is to send all of our confirmed negatives there, as long as they're able to be transported. So I kind of agree with Jordan in the idea of like trying to partner with some of those hubs and figure out a way, because I mean, realistically, as this progresses, like the health system that I work at, this primary hospital is only going to be serving COVID patients, or if you come here, you're going to get it. So offering beds, and then that'll help your bottom line as well.
Great. Thanks, Annie.
Hey, Allie, it's Elise. I definitely want to keep in touch with you on this topic. I work for a medical lab, and we're affiliated with a very large health network. Basically, we have a huge drop in like our normal testing, because people aren't going out to get their normal blood work, even if they have, you know, issues where they have normal blood work to get done, that type of thing. As much as you might think we're running tons of COVID testing, obviously we know that there's a shortage of testing kits. So I don't have an answer, but I just wanted you to know that we're also feeling it on the lab side as well. And business, we don't really know what's going to happen. So I'll keep in touch with you about that. Maybe we can keep a conversation going.
Awesome. That's great. Thanks.
Okay. Does anyone, let's see, I'm looking for people with their hands up here.
Aaron, this is Scott Siegfried. Can you hear me now?
Oh, yeah. Yes, we can. Yes, thank you.
Cool. Yeah. No. So kind of related to this topic, and I was just wondering. I mean, it sounds like there's a lot of great process improvement things going on with most people. I was curious. So I'm part of a larger health system in the Northeast, and we are gearing up for what we expect to be a pretty decent surge because we're right on the border of Pennsylvania and New Jersey, and we're already starting to see a lot of it in our hospitals. But in the meantime, with a lot of elective surgeries being canceled, keeping our ORs quiet, we have seen a significant volume drop off on our inpatient side, and financially, we are being hurt pretty bad right now. And I'm just curious if anybody else out there has been asked the question to help try and figure out expense reduction initiatives, and looking at, labor, other things that you can do in the interim, sort of while you're waiting for this surge to happen, to try and keep some of the losses at bay. Is anybody out there kind of working on that, or has anybody been asked that, or is that unique to us right now?
Hey, this is Joyce Siegley. Can you hear me?
Yes.
Hey, we've been very involved in that. I do a lot with labor management, and we have been doing a lot with expense reduction, specifically related to, for example, prior to all this happening, we were having to use like contracted labor or outside labor, or even looking at, all of the different premium pay options that are out there. And we've been focused extremely heavily on reducing and eliminating all of that, from a cost perspective. And then I know that some of the finance folks are obviously looking at capital and supplies, because it is going to be a huge, component of what we're going to have to do to maintain the financial health of all of our healthcare systems with what's going on right now. So we have been, and that's what we've been focusing on. If you need more specifics, I mean, I'm happy to help, with that too, but that's going to be a key thing, I think, is, we have to help with the fact that our revenues are dropping. So we have to help with the expense reduction as well.
Great. Yeah. Thanks for that insight. It's definitely an odd environment to be in because things are going to very different directions at times, and it's tough to sort of manage both sides of it.
Yes, definitely.
It looked like Elise, did you have your hand up again? Did you have something to contribute? I couldn't tell if that was left over from the last time.
Sorry, it was left over.
Oh, that's okay, no problem.
No problem. No problem. Okay, we've got about 6 minutes left here. So does anyone have either anything to contribute or any question that you have with, at your health system or with your role that you'd like, some insight on from the rest of the team?
Aaron, this is Scott Siegfried again. I did have one other question for the group. To some of the people who are working on modeling and projecting your COVID-19 cases, how have you been handling sort of graphing out the peak? And has anybody been able to figure out, like, I don't want to say just loosely like an equation to the line or like a distribution that makes sense in this case? You know, we had toyed around with some engineer or simulation models, but it's like, how do you make your cases arrive with a lot of unreliable data out there? So I was just curious if anybody had any luck or suggestions for that.
Yeah, so this is Jordan. You know, one thing you'll find, and I was just playing with that Coventus model as well, is that a lot of them jump on that assumption that there's a certain doubling time, and then they just keep that going in infinitum, right? So the Coventus model that I just tried it out just showed me that, by May I'll have 6,241 med surg cases, and I severely doubt that. Given a 15% admission rate, that would make it almost like that would mean the statewide we'd have basically everyone in the state has COVID at that point, all 1.3 million and all that. So you have to. I think a lot of simulation models are just trying to use this doubling time to figure out when your hospital will get overrun, assuming that that's going to happen before the actual spread of the disease caps out. And so the fact that they, as you go into the long-term forecast, the fact that they're over forecasting is irrelevant because the run on the hospital is still going to happen. What I did actually, I found there was a model, basically there's a lot of complex models here. You could do the SEIR modeling and differential equation modeling and simulation modeling and all that. But in the end, without knowing where this is going to end and without knowing how to quantify the effect of social distancing, there's just no great way to do it. The way I've decided to do it is just fit it to a logistic curve, and I just made the overall assumption that we will get in 1 month about the same amount of COVID cases as we did flu cases in an entire year. So Maine has about 10,000 flu cases in a year, so I'm saying we'll get 10,000 COVID cases in a month, and then it'll cap out. And then what I'm doing is just as data comes in every day, I'm refitting my curve and checking to see whether this assumption still holds. At the moment, it does. I did the same thing for Italy, and I'm tracking the Italian data using this curve. And I translated the Italian public health records to get their flu rates. Thank goodness for Google Translate. And at the moment, that assumption is kind of holding. They're targeting about the same amount of COVID cases as they do have flu cases. So I don't have a good reason to say why I'm comparing it to the flu, but it just gave me some, target to shoot for. And I'm just updating the data as I go.
Great, Jordan.
Does that help? Does that help at all?
It does. Thanks, Jordan. I appreciate it.
Sure.
All right. So we're about out of time here. I really appreciate everyone getting on today. By the way, we had 50 people on this discussion today, which is pretty awesome. Allie and I were texting throughout this. We thought this was such a good conversation. There's probably so many more questions that people have and thoughts that people have that as this thing evolves, it may be good to have something similar. So we were going to propose potentially doing another call in 2 weeks because we may be in a different place, all of us, in 2 weeks. And it might be good to check back in with this team or people like you again. Do people think that would be a good idea?
Yes.
Yes.
Okay.
Absolutely.
Yeah. Okay. All right. We'll set another one up for April 10th. We'll do the same time because it seemed to work for 50 people. So we'll try it again. We'll do April 10th at 2 p.m. And we'll do 2 p.m. Eastern. We'll do the same thing. Thank you for everyone that contributed today. Avi for kicking off with some information at the beginning, Jordan for all your input, and everyone else that, with your questions. What I'll try and do maybe before the one on the 10th is get questions from people so we can kind of have them out there and people can ask their question as we go along. And if there are similar questions, we can make sure it's a discussion topic for everyone. But I thought this kind of free form worked pretty well.
Hey, Aaron, it's Josh.
Yeah.
So shameless plug, we just started that SHS Young Professionals LinkedIn group. Would you be able to send out just the link to everyone that accepted on this? And maybe that could just be another forum just for open discussion?
Yes, definitely. Yep. I will do that. All right. Thank you all very much. Hang in there and keep solving those unique problems. I appreciate what everyone's doing.
Thanks, Aaron.
Talk to you all later.
Thank you very much.